Well, hello everybody, this is Dr. Raynaud'S, and in today's video, we'll be studying about Raynaud's phenomenon. So, Raynaud's phenomenon was first described by Raynaud in 1862. This is characterized by a phenomenon of paroxysmal pallor with coldness of extremities. This is precipitated by cold. Coming to the hallmark feature of RP, there is going to be ischemia of digit, which occurs in response to cold. Along with this, there is going to be a characteristic triphasic color pattern. That is, there is going to be pallor, cyanosis and rubor along with numbness and swelling. Coming to the pathogenesis of Raynaud's phenomenon, there are various factors that come into role. First is the vascular, second is the neural, and third is the intravascular cause. The vascular causes can be because of structural and functional changes in the vessels, whereas the neural causes include decrease in CGRP levels, where CGRP acts as a vasodilator. It can also occur as a result of alpha 2C adrenoreceptor activation and also because of some CNS component. Coming to the intravascular causes, platelet activation, impaired fibrinolysis and increased viscosity of blood along with oxidant stress also play a role. The hormonal factors include estrogen, which causes alpha 2C activation. There can be a genetic involvement. It can be associated with smoking and also vibratory stimuli. The vasoconstriction in Raynaud's phenomenon is by reflex sympathetic release of norepinephrine along with increased sensitization of the vasculature. Coming to etiology, basing on the etiology, Raynaud's phenomenon is of two types: primary Raynaud's phenomenon and secondary Raynaud's phenomenon. As it is self-explanatory, primary Raynaud's phenomenon has no identified etiology and it is also known as Raynaud's disease. So Raynaud's disease is nothing but primary Raynaud's phenomenon. Then it's the secondary Raynaud's phenomenon. It is associated with various factors such as connective tissue diseases such as systemic sclerosis, systemic lupus erythematosus and Sjogren's syndrome. It can be associated with arterial diseases such as thromboarteritis obliterans or any atheroma. It can be associated with drugs and toxic agents such as beta blockers, ergot derivatives, bleomycin, cyclosporin, or it can be due to some endocrine disorders such as hypothyroidism, carcinoid syndrome, pheochromocytoma, or it can be because of some hematological disorders such as polycythemia vera, cold agglutinin disease, cryoglobulinemia. It can be associated with malignancies such as myeloproliferative and lymphoproliferative disorders, or it can be associated with neurological disorders such as carpal tunnel syndrome, hemiplegia, multiple sclerosis, and poliomyelitis. Now, coming to the differences between primary and secondary Raynaud's phenomenon. Primary Raynaud's phenomenon, also known as Raynaud's disease, has no known etiology, whereas secondary Raynaud's phenomenon has various etiologies as described above. Primary Raynaud's phenomenon is precipitated by cold and emotional stress, whereas secondary Raynaud's phenomenon is precipitated by cold alone. The basic pathogenesis is functional alteration in primary Raynaud's phenomenon, whereas structural microvascular abnormalities play a role in secondary Raynaud's phenomenon. The median age of onset is 14 years in Raynaud's disease, whereas it is seen in more than 30 years of age group in secondary Raynaud's phenomenon. Both commonly occur in females. However, in primary Raynaud's phenomenon, the male is to female ratio is 1:5 or female is to male ratio is 5:1, whereas secondary Raynaud's phenomenon depends on the underlying disease. However, most of the diseases described above that are known to be associated with secondary Raynaud's phenomenon are seen in females. Coming to the nail involvement, there is no nail involvement in primary Raynaud's phenomenon. However, if it is to occur, it is only mild and can be seen as nail fold capillary abnormalities, which are usually mild. Whereas in secondary Raynaud's phenomenon, the nail can be enlarged or deformed and capillary loops are seen on nail fold capillaroscopy, along with nail fold telangiectasias and nail clip thinning. The nail involvement is symmetrical and many digits are involved in Raynaud's disease, whereas it is asymmetrical and only few digits are involved in Raynaud's phenomenon secondary. The skin necrosis is rare in primary Raynaud's phenomenon, whereas it is not uncommon, that is, it is commonly seen in secondary Raynaud's phenomenon. ESR is usually normal in Raynaud's disease, whereas it is elevated since it occurs secondary to various diseases in secondary Raynaud's phenomenon. The anti-nuclear antibody test is negative in Raynaud's disease, whereas it is positive if secondary Raynaud's phenomenon is occurring in association with connective tissue disorders. The prognosis is good in primary Raynaud's phenomenon, whereas it depends on the underlying disease in secondary Raynaud's phenomenon. Frequency of attacks is less than 5 attacks per day in Raynaud's disease, whereas the attacks can range from 5 to more than 10 per day in secondary Raynaud's phenomenon. So to summarize, Raynaud's phenomenon and Raynaud's disease differ from each other in the fact that Raynaud's disease is seen in lesser number of population, that is only 3 to 5% of the population, and it is more common in women of less than 40 years of age, or it is more common in adolescent women and women of younger age group. It affects hands, the two symmetrically, and feet are less involved. Tongue involvement and pulmonary hypertension may be present, and it usually has good prognosis. Coming to the diagnosis, first, taking history is really important to rule out various causes or to find any underlying etiology. The history should be taken pertaining to any history of frostbite, occupation of the patient, if there has been any exposure to polyvinyl chloride. And it is also important to elicit the attack if the history is non-explanatory. Physical examination of the digits to look for any change in colors and also presence of ulcers is necessary. Lab investigations such as complete blood picture, erythrocyte sedimentation rate, random blood sugar level, lipid profile, checking the hypercoagulability state, urea and electrolytes, anti-nuclear antibody tests and rheumatoid factor rule out autoimmune diseases is necessary. Nail fold capillaroscopy to detect any changes in the nail fold capillaries, angiogram of the hand, arterial Doppler and duplex scan to look for any vessel wall abnormalities, laser Doppler flux scan, X-ray of the affected site, assessment of segmental BP gradient, cold stimulation test and reactive hyperemia time are some of the tests that are done to diagnose Raynaud's phenomenon. Coming to complications, secondary nail changes such as sclerodactyly, thinning of nails, pterygium formation, development of nail fold capillaries, pitted scars, digital ulcers, and loss of hair of the affected area are seen. Management is multidisciplinary. First line is always prevention of the attacks. So this is done by avoiding precipitating factors such as cold by wearing gloves and using hand warmers. Avoiding smoking and avoiding any vibratory tools and treating the underlying cause from the first line of therapy. Coming to the second line, vasodilators, most commonly calcium channel blockers are used. Of the calcium channel blockers, nifedipine 20 mg is usually given. Third line agents include phosphodiesterase 5 antagonists such as sildenafil, alpha adrenergic blockers, ARBs, endothelin receptor antagonists like bosentan are given. In the fourth line, serotonin antagonists, that is SSRIs such as fluoxetine are selected. Coming to the other drugs, angiotensin converting enzyme inhibitors, nitrates, low-dose aspirin, steroids, topical nitroglycerin, epoprostenol which is a prostaglandin and acts as a vasodilator, iloprost which is a prostacyclin analog, misoprostol which is oral prostaglandin E1, rituximab, botulinum toxin A, sympathectomy such as selective, cervical, lumbar or percutaneous thoracic and plasma exchange can be tried.